Dr. Sachs?
Good afternoon. I want to welcome you to our presentation of intermittent outpatient infusion of necessitide patients with decompensated congestive heart failure. My co-authors and I want to thank the American College of Chest Physicians for giving us an opportunity to present these data. The authors have no financial interest to disclose. LV dysfunction, regardless of its cause, results in characteristic hemodynamic derangements and a process of neurohormonal activation, including the sympathetic nervous system, renin-angiotensin-aldosterone system, and the endothelin pathway. Each of these pathways has hemodynamic effects that maintain tissue perfusion and blood pressure. Although these responses initially compensate for hemodynamic derangements, prolonged elevation of norepinephrine, renin, angiotensin 1-2, aldosterone, and endothelin becomes directly toxic to the heart, accelerating processes such as apoptosis, myocyte hypertrophy, and interstitial fibrosis. Natriuretic peptides represent a favorable side of neurohormonal activation. Natriuretic peptides are produced by the heart and vasculature and improve the loading conditions of the heart failure through their diuretic, natriuretic, and vasodilatic properties. Beta-type natriuretic peptide, which was initially called brain myocardial response to elevations of end-diastolic pressure and volume. From a physiologic standpoint, beta-type natriuretic peptide has an important role in congestive heart failure as counterregulatory hormone to angiotensin 2, norepinephrine, and endothelin because it decreases the synthesis some of these neurohormones and acts like a valence vasodilator. Furthermore, as a result of its hemodynamic effect and its direct tubular action, beta-type natriuretic peptide has both natriuretic and diuretic effects. Necessitide, a recombinant form of human beta-type natriuretic peptide, has been improved for the treatment of patients with acutely decompensated heart failure. Our study is a single-center prospective observational design of patients with chronic decompensated or congestive heart failure. At the time of the design of the study, there was substantial disagreement and conflicting data regarding the effectiveness of using intravenous necessitide in the outpatient setting in patients with chronic decompensated congestive heart failure. The drug was initially approved for use in patients with acute decompensation of heart failure. Preliminary results of FUSION-1 were not conclusive. Several other studies suggested that the use of necessitide in these patients may be associated with renal toxicity. There was some data suggesting that necessitide was actually associated with increased mortality. Our study was designed to follow a large group of patients with decompensated chronic heart failure in the outpatient setting to determine whether or not necessitide could be of symptomatic benefit to these patients without undue risk of renal toxicity. Enrollment began in May of 2004, and patients were followed for a minimum of 12 months. Patients were eligible for inclusion if they had previously been diagnosed with congestive heart failure due to left ventricular systolic dysfunction. Patients had to be on maximally tolerated guideline-based therapy and still symptomatic. All patients had to have had at least one admission to the hospital for acute decompensation in the previous 12 months. All patients were asked to fill out the Kansas City Heart Failure Questionnaire at the start of the study and prior to drug protocol initiation. Baseline clinical characteristics, laboratory data, and measurement of creatinine clearance were recorded. Patients underwent 2D echocardiography with Doppler color flow and tissue Doppler measurements. Patients had baseline non-invasive hemodynamic assessment with impedance plethysmography. Creatinine clearance was measured directly at baseline, 3 months, and again at 12 months. The number of hospital admissions for acute decompensation was recorded for the 12 months prior to initiation of the study protocol and throughout the study protocol. Patients were evaluated with Kansas City Heart Failure Questionnaire. This heart failure survey document is a several-page self-administered questionnaire designed to reliably, reproducibly score a patient's overall clinical and symptom heart failure status. The questionnaire has been used in multiple larger heart failure trials, including the FUSION trials, and is designed to be reliable, reproducible, and have excellent correlation with New York Heart Association classification. The lower the scoring, the worse the patient's symptoms and condition, and the lower the New York class. In our study, patients were asked to complete the survey on admission to the study at 3 months and a follow-up at least 1 year post-study. Patients were included in the study if they had 2 or more heart failure hospitalizations or the equivalent within 12 months, with the most recent within the prior 60 days. Hospitalization equivalent was defined as an unscheduled outpatient treatment for acute decompensated heart failure with intravenous vasoactive drug treatment for acute decompensated heart failure. Or 3 unscheduled intravenous diuretic treatments for acute decompensated heart failure within 60 days. Other eligibility criteria included left ventricular ejection fraction less than 40% within 24 weeks. Investigative documentation of consistent New York Heart Association class 3 or 4 symptoms during the previous 60 days with an estimated creatinine clearance less than 60 mL per min, calculated Cobb equation of 24-hour urine collection, and optimal treatment with oral medications, and device therapy unless a documented contraindication or intolerance was present. These criteria are similar to those used for Fusion 1 and 2 trials. Patients were excluded from participation for any of the following reasons: systolic blood pressure less than 90 millimeters of mercury, dependence on or inability to discontinue intermittent or continuous intravenous vasoactive medications, greater than 2 outpatient infusions of vasoactive therapy within 30 days without a hospitalization, implantation of biventricular pacemaker within 45 days, or prior single or dual chamber pacemaker, implantable cardioverter defibrillator within 30 days, cardiogenic shock or volume depletion, and chronic dialysis. The exclusion criteria are consistent with those criteria of other major heart failure trials evaluating muscular or intravenous inotropic therapy. Patients had to be willing to give informed consent for inclusion in the study and participation with a 10-week infusion protocol. Within 14 days of enrollment in the study, patients underwent completion of all baseline studies before receiving initiation of the study drug infusion protocol. All current drug therapies were continued. Patients were then assigned to the clinic for 3 times per week sessions for 10 weeks. Patients received an intravenous bolus of muscular of 2 micrograms per kilogram given over a 2 to 5 minute duration, and patients were then placed on a continuous intravenous infusion of nesirotide of 0.01 micrograms per kilogram from in for 3 hours. Results. During the study enrollment period, there were 109 patients who met the inclusion criteria. 26 patients were excluded or unwilling to participate or give consent. 6 patients were on dialysis. 2 patients had 5 ventricular pacemakers, and 8 patients had received ICTs. 3 patients met the inclusion criteria and were enrolled in the study. Baseline characteristics. The mean age of the patients was 81 years old, 63.4% were male, 90.2% were white. The mean ejection fraction of the patients at the start of the study protocol was 27%. We determined the primary etiology of a heart failure through evaluation of the medical record. The overwhelming majority of patients' heart failure was due to underlying ischemic cardiomyopathy. Alcohol was primary in 4 patients, hypertension in 5 patients, and in 2 patients, diagnosis of idiopathic cardiomyopathy was made. Clinical characteristics of the study group were similar and consistent with that seen in other primary heart failure trials and general cardiology practice. The majority of patients had comorbid conditions of hypertension, prior myocardial infarction, and lipid disorders. 23% were diabetic, 18% had documented peripheral vascular disease, 85% of patients were New York Heart Association classification 3, and 15% of patients were New York Heart Association class 4 at the time enrollment into the study. Prior to entry into the study protocol, all patients had to be on optimal evidence-based heart failure therapy according to current American Heart Association / American College of Cardiology guidelines. 62.2% patients were on a loop diuretic. 81.9% were receiving an ACE inhibitor or angiotensin receptor blocker. 50% were on nitrates, either oral or topical, and 42.7% were on digitalis preparation. A quarter of the patients were on an aldosterone inhibitor. Results are presented with mean values and 95% confidence limits. The mean New York Heart Association class prior to the study protocol was 3. There was a mean drop of 1 class, and the result was statistically significant with a p-value of less than 0.0001. Left ventricular ejection fraction improved from a mean of 27.4% to 34.6%. This result was also statistically significant. Cardiac output and systemic vascular resistance as measured by impedance spasmography both improved. Cardiac index increased from 2.7 3.5 liters per minute per meter squared body surface area. Systemic vascular resistance decreased from 1299 to 1124. Kansas City Heart Failure Questionnaire was used in our study as a survey tool to objectively quantify clinical and symptomatic function in patients with chronic heart failure. In our study, there was a clinically and statistically significant improvement in Kansas City Heart Failure Questionnaire scores with their treatment protocol. There has been conflicting data regarding the effect of nesirotide on renal function. in these patients. So one of our primary endpoints was to evaluate whether there was a significant adverse effect of nesiritide on renal function. We did not find a significant difference in renal function with the use of outpatient intermittent nesiritide in patients with chronic decompensated heart failure, as measured by creatinine or creatinine clearance. In conclusion, patients with severe left ventricular dysfunction and chronic decompensated heart failure remain significantly symptomatic despite guideline-based therapy. Intermittent outpatient infusion of nesiritide is effective in improving symptoms in patients who already optimized with evidence-based therapy. Intermittent outpatient infusion of nesiritide improves hemodynamics as measured by impedance spectroscopy with significant increases in cardiac index and decreases in systemic vascular treatment. Also, intermittent outpatient infusion of nesiritide in patients with chronic decompensated heart failure increases the left ventricular ejection fraction as measured by two-dimensional echocardiography, and reduce hospitalizations and improve the quality of life as measured by the Kansas City Heart Failure Questionnaire. In our study, there was no significant adverse effect on renal function and no deaths in the 12-month follow-up period. However, our study was not designed with survival as an endpoint and not a randomized